Welcome back to the deep dive. Today we're tackling something, well, incredibly complex, but absolutely central to how our bodies function. We're going deep into the hypothalamic pituitary
Yeah,
axis.
it sounds technical, but this tiny bit of the brain, the master gland, as it's often called, has just enormous influence.
It really does, and we're digging into how things can go wrong.
Exactly. We've got a pile of clinical notes, research snippets here, all focused on diseases of the pituitary. And what's fascinating, and frankly sometimes devastating, is how tiny disruptions, a small tumor, maybe a drug side effect, even a shock to the system like blood loss, can cause these huge ripple effects.
Affecting everything from metabolism, growth, reproduction, even just basic water balance.
Precisely. So our mission today, looking through these sources, is really about decoding the signals. How do these diseases present?
And crucially, what's the big question we need to keep asking as we go through this material?
I think it's this. How do you, as a clinician, or even just someone trying to understand this, tell the difference between a problem starting right here in the pituitary, what we call central failure, versus a problem out in the target gland, like the adrenals or the thyroid?
Because getting that distinction right can be absolutely life-saving, can't it?
It absolutely can. Often, the clue is subtle. Maybe one hormone level that's unexpectedly normal when others are low, or one that's wildly high. Those contrasts are key.
Okay, let's get into it. Where should we start? Maybe with what happens when the pituitary goes into overdrive, the consequences of too much signal.
Sounds like a good plan. Let's start with hormonal overproduction.
First up, acromegaly. This is the one people might vaguely recognize from, well, striking physical changes.
Right. At its core, acromegaly is about having way too much growth hormone, or GH. And almost always, this comes from a specific type of pituitary tumor, a somatotroph adenoma, just churning out GH constantly.
But our sources really emphasize something interesting. GH itself isn't the direct villain here, is it?
Not entirely. GH is the signal, the messenger. It travels to the liver, and the liver responds by producing insulin-like growth factor 1, or IGF-1. And it's really the IGF-1 that drives most of the physical changes, the tissue growth, the bone remodeling.
So IGF-1 is the downstream effector, the architect of the damage.
Exactly. It stimulates growth in soft tissues, cartilage, bone, basically everywhere. And the thing is, it's usually incredibly slow, insidious.
So people don't notice it overnight?
No, not at all. It can take years, sometimes decades, for the changes to become obvious enough for someone to seek help. That's why the diagnosis is often delayed.
What are those classic physical clues we should be looking for, according to these notes?
Well, the face is often where it's most striking. You get coarsening of the features, the forehead becomes more prominent, that's called frontal bossing.
Yeah.
The jaw enlarges, macronathia.
And that widens the spaces between the teeth, right?
Yes, increased interdental spacing, that's a classic sign. And then look at the extremities.
Hands and feet get bigger.
Significantly larger. Fingers and toes thicken. The palms often feel different, sort of oily, sweaty, almost doughy to the touch because of the soft tissue swelling. Skin tags are also common.
And what about joints? I see mentions of severe arthritis.
Oh, absolutely. That's often one of the most debilitating parts. IGF-1 makes cartilage and synovial membranes grow, leading to really painful joints, arthralgias, and widened joint spaces on x-rays. It can look like severe early-onset osteoarthritis, which sometimes leads down the wrong diagnostic path initially.
Okay, so diagnostically, this seems tricky. If IGF-1 is the problem marker, why don't we just measure GH levels directly? That feels more intuitive.
Yeah, it does seem logical. But here's the catch. GH is released in pulses. Its levels jump up and down throughout the day. A single random GH measurement, pretty much useless. It could be high, could be low, even in a healthy person.
So it fluctuates too much.
Exactly. That's why IGF-1 is the go-to initial test. It hangs around longer in the blood, it's much more stable, and it gives you a better picture of the average GH production over time. If IGF-1 is high, then you know something's up.
Okay, so high IGF-1 flags suspicion. How do you confirm that the pituitary is definitely the source, that it's releasing GH on its own, ignoring normal controls?
That's where the oral glucose suppression test comes in. It's a definitive test. Normally, if you drink a sugary glucose load, your GH level should plummet. Glucose is a powerful natural suppressor of GH.
Makes sense.
But in acromegaly, that pituitary tumor doesn't care about the glucose signal. It just keeps pumping out GH. So during the test, the GH level fails to suppress adequately. Sometimes it even paradoxically rises after the glucose load.
Wow, so that confirms the autonomy of the tumor.
Precisely. So the sequence is key. Screen with IGF-1, confirm with glucose suppression, and then you get an MRI of the pituitary to find the adenoma.
Now, let's talk about the really scary part highlighted in these sources, the mortality risk. It's significantly increased, isn't it? And not just from the tumor itself.
No, the biggest danger, the leading cause of death in untreated acromegaly, is cardiovascular disease. This is critical.
How does excess GHIGF-1 damage the heart?
They act as potent growth factors for the heart muscle too. They cause both the muscle cells, the cardiomyocytes, to get bigger and also stimulate the growth of other cells in the heart. The result is what's called acromegalic cardiomyopathy.
And what does that look like structurally?
The hallmark is concentric left ventricular hypertrophy LVH. The walls of the main pumping chamber, the left ventricle, thicken uniformly inwards.
Okay, so the walls get thicker. How does that impair function? Is it harder to pump?
Initially, the problem isn't pumping out, it's relaxing in. The thickened muscle becomes stiff. It can't relax properly between beats to fill up with blood efficiently. That's diastolic dysfunction.
So filling is impaired first.
Yes. But over time, that strain and abnormal remodeling leads to problems with squeezing to systolic dysfunction. And that progresses to heart failure. Plus, there's a higher risk of dangerous arrhythmias.
And distinguishing this concentric LVH from other types, like the asymmetric thickening you see in, say, hypertrophic cardiomyopathy, is important.
Very important because it points directly back to the hormonal cause of the acromegaly. And the good news, really, is that if you treat the acromegaly, effectively normalize the GH and IGF-1, usually with surgery or medication, you can often halt or even partially reverse this heart damage.
So early diagnosis and treatment directly impacts cardiac survival.
Absolutely. It dramatically reduces that mortality risk. Time is heart muscle here.
Okay, let's shift gears. From a tumor causing excess growth, let's talk about the most common type of functional pituitary tumor, the prolactinoma. This one works more by inhibition, right?
Exactly. This is a classic example of the pituitary disrupting its own chain of command. The tumor just pours out prolactin.
And prolactin's main job, outside of pregnancy and lactation, is essentially to put the brakes on reproduction.
That's right. It acts directly back on the hypothalamus, the level above the pituitary.
Walk us through that inhibitory cascade. How does high prolactin shut things down?
Okay, so the excess prolactin tells the hypothalamus to stop releasing gonadotropin-releasing hormone, GnRH, in its normal pulsatile way.
Yeah.
GnRH is the master switch for the reproductive system.
So cut off the GnRH signal?
And the pituitary itself gets the message. Stop making follicle-stimulating hormone, FSH, and luteinizing hormone, LH.
Which are the hormones that tell the ovaries and testes what to do.
Precisely. Without FSH and LH, the gonads basically shut down. You end up with central hypogonadism, low estrogen in women, low testosterone in men, all because the starting signal from the brain is suppressed.
And the symptoms follow directly from that hormone loss.
Yep. In women, the classic signs are irregular periods or no periods at all, oligomenorrhea or amenorrhea. Galactorrhea is common too, producing milk when not breastfeeding. And infertility, obviously. Plus, low estrogen causes things like vaginal dryness.
And in men. I gather it can be less obvious sometimes.
Often subtler, yes. Things like decreased libido, maybe erectile dysfunction, sometimes gynecomastia, which is breast tissue development. Men might not connect these symptoms as quickly to a hormonal issue.
Now, here's a clinical pearl from the sources that seems really important. When we treat prolactinomas, especially the smaller ones, the microdenomas, the main long-term goal isn't always just fixing the periods or libido, it's about bone health.
Absolutely crucial point. This is often the driving reason to treat symptomatic prolactinomas, even if the tumor itself is tiny. Estrogen is vital for maintaining bone density. It keeps the bone-resorting cells, the osteoclasts, in check.
So when estrogen is chronically low because the prolactin-induced GnRH suppression,
Those osteoclasts go wild. Bone breakdown outpaces bone formation. Over years, this leads to significant bone loss osteoporosis and a much higher risk of fractures later in life. So treating the prolactinoma allows estrogen levels to recover and protects the skeleton.
protecting the patient's future bone health is a primary goal.
Okay, so how do we diagnose this? How do we know it's a prolactinoma versus something else causing high prolactin?
The level of prolactin is a huge clue. If the level is really, really high, typically over 200 nanograms per milliliter, that strongly suggests a prolactinoma, usually a larger one, a macrodenoma.
And if it's elevated, but not that high, say in the 25 to 200 range.
That's more of a gray area. It could still be a small prolactinoma, a microadenoma.
Yeah.
But very importantly, that moderate range is also where you see elevations from other causes. Things like certain medications, especially antipsychotics, which we'll touch on later, or even conditions like severe primary hypothyroidism. High TRH and hypothyroidism can nudge prolactin up a bit.
So a level over 200 almost certainly means tumor. Get an MRI. A level between 25 and 200 means could be a small tumor, but definitely check medications and thyroid function first.
That's a great summary of the approach. The magnitude guides the next steps.
All right, we've covered the pituitary work in overtime. Now let's talk about the opposite scenario, pituitary failure. When the master gland shuts down. And let's start with a really dramatic example, Sheehan syndrome.
Ah, yes. Sheehan's is probably the most stark illustration of the pituitary's physical vulnerability. It's essentially a stroke of the pituitary gland.
Caused by what exactly?
It happens after severe postpartum hemorrhage, massive bleeding after childbirth that leads to profound hypotension, a big drop in blood pressure. The pituitary suffers ischemic necrosis. It dies from lack of oxygen.
But why is the pituitary so uniquely susceptible during pregnancy? Lots of organs are stressed by massive blood loss, but they don't all infarct like this.
It's down to the specific changes pregnancy induces in the pituitary itself and its peculiar blood supply. During pregnancy, the prolactin-producing cells, the lactotrophs, multiply massively. The gland can actually double in size to prepare for lactation.
So it's bigger and working harder?
Exactly. But the blood supply to the anterior pituitary, which makes most of the hormones we're talking about, comes from a very low-pressure network of veins called the hypophyseal portal system. This blood supply doesn't expand to match the gland's increased size and metabolic demand.
So you've got this enlarged hyperactive gland being fed by a relatively fragile, low-pressure blood system.
Precisely. So when the mother has a major hemorrhage and her systemic blood pressure crashes,
Yeah.
that low-pressure portal system just collapses. Blood flow stops, the anterior pituitary cells are starved of oxygen, and they die.
And you mentioned the anterior pituitary specifically. The posterior pituitary is spared.
Usually, yes. The posterior pituitary gets its blood supply directly from arteries, which is a higher pressure system and less vulnerable to that kind of hypotensive shock. This distinction is key to the symptoms.
Okay, so the anterior pituitary is wiped out. What are the classic clinical signs that result from losing those specific hormones? Is there a typical triad?
There is, though it might take weeks or months to become fully apparent. The first and most defining sign is usually failure to lactate. No milk production because the prolactin cells are gone.
Makes sense. What else?
Next, loss of FSH and LH leads to ongoing amenorrhea, no return of periods after delivery and infertility, and then, critically, the loss of ACTH.
Adrenocorticotropic hormone, the signal for cortisol production.
Right. Losing ACTH leads to secondary adrenal insufficiency, cortisol deficiency, and that causes severe fatigue, weakness, loss of appetite, low blood pressure, especially orthostatic hypotension, where you get dizzy standing up. This is a life-threatening part.
Okay, so that cortisol deficiency is the immediate danger. And this brings us to a really critical management point from our sources. When you have pituitary failure, like in Sheehan's, you can't just replace all of the missing hormones at once, can you? There's a specific order.
This is incredibly important, probably one of the highest yield takeaways. You must replace the glucocorticoids, give hydrocortisone to cover the missing cortisol, before you replace the thyroid hormone with levothyroxine.
Why is that sequence so vital? What happens if you give thyroid hormone first?
If you give thyroid hormone first to someone who is cortisol deficient, you essentially rev up their metabolism. Thyroid hormone increases metabolic rate, increases tissue demands, but critically, it also increases the rate at which the liver clears any tiny amount of cortisol the person might still be making.
So you accelerate the breakdown of their already low cortisol?
Exactly. You push them from chronic adrenal insufficiency into an acute adrenal crisis. Profound shock, vascular collapse. It can be fatal very quickly. You have to give the stress hormone, the cortisol replacement, first to stabilize them before you increase their metabolic demands with thyroid hormone. Cortisol first, always. Hashtag 2.2 secondary adrenal insufficiency, the aldosterone clue.
That perfectly sets up our big question, again, differentiating primary versus secondary problems. Let's focus on adrenal insufficiency. If someone has low cortisol, how do we pinpoint if the failure is in the adrenal glands themselves? Primary AI, Addison's disease, or if it's the pituitary not sending the signal, secondary AI.
This is where understanding the different layers and controls of the adrenal gland is key. And the big clue, the differentiator, is the hormone aldosterone.
Okay, remind us about aldosterone's role.
Aldosterone is crucial for salt and water balance and blood pressure regulation. It's made in the outermost layer of the adrenal cortex, the zona glomerulosa. Cortisol is made in the inner layers, the zona fasciculata and reticularis.
And what controls these different layers?
This is the crucial part. Cortisol production is almost entirely dependent on the ACTH signal from the pituitary. No ACTH, no cortisol. But aldosterone production is mainly controlled by the renin-angiotensin system, RAAS, which responds to blood pressure and kidney perfusion, and also by potassium levels. ACTH has only a very minor effect on aldosterone.
Ah, okay. So in secondary AI, the pituitary isn't making ACTH, so cortisol will be low.
Correct.
But because the RAAS system is still working fine in response to maybe low blood pressure, the adrenals can still make aldosterone normally.
Exactly. That's the key distinction. In secondary or central adrenal insufficiency, you have low ACTH, low cortisol, but normal aldosterone.
Got it. Now contrast that with primary AI, Addison's disease, where the adrenal gland itself is destroyed, often by autoimmune attack.
In primary AI, the whole adrenal cortex is damaged all the layers, so you lose the ability to make both cortisol and aldosterone. Both are low.
And what does the pituitary do in response to that?
Because there's no cortisol coming back to provide negative feedback, the pituitary goes into overdrive trying to stimulate the failing adrenals.
Right.
It pumps out massive amounts of ACTH.
So in primary AI, ACTH is high, whereas in secondary AI, ACTH is low. That's a huge difference.
A fundamental difference. And that high ACTH in primary AI gives us another classic sign.
The hyperpigmentation.
Yes. ACTH is derived from a larger precursor molecule called POMC, pro-opiomelanocortin. When POMC is cleaved to make ACTH, it also releases other fragments, including melanocyte-stimulating hormone, MSH. So massively high ACTH comes with massively high MSH.
The MSH stimulates melanin production.
Leading to that characteristic darkening of the skin, especially in sun-exposed areas, creases, scars, even the gums inside the mouth. You don't see hyperpigmentation in secondary AI because ACTH is low.
Okay, so let's nail the clinical takeaway. Secondary AI, low ACTH, normal aldosterone, no hyperpigmentation. Symptoms are mainly due to low cortisol, fatigue, mild low BP. Primary AI, high ACTH, low aldosterone, hyperpigmentation. Symptoms are much more severe due to loss of both cortisol and aldosterone, risk of severe dehydration, low sodium, high potassium, shock.
That's the perfect summary. The aldosterone status and the ACTH level plus hyperpigmentation tell you exactly where the problem lies. Hashtag 2.3 non-function. Pituitary adenoma, the silent mass.
We've talked about tumors making too much hormone like GH or prolactin. But what about pituitary tumors that don't seem to make any active hormone? The non-functioning adenomas, these are common too, right?
They are, making up maybe a third of all pituitary tumors. They often arise from the gonadotroph cells, the ones that are supposed to make FSH and LH.
So why are they non-functioning or silent?
It's a bit subtle. They often do secrete something, but it's usually just fragments of hormones like the alpha subunit common to FSH, LH, TSH, and HCG, or maybe abnormally structured beta subunits. These fragments aren't biologically active.
So the body can't use them. The tumor is growing, maybe secreting junk, but there's no hormonal excess syndrome like Cushing's or acromegaly.
Exactly. Which means these tumors often grow quite large before they cause any symptoms at all. And when they do cause symptoms, it's usually not because of hormones, but because of their physical size, mass effect, and compression.
Let's break that down. Mass effect, what happens when this tumor gets big inside that tight bony space, the sella turcica?
Well, simple pressure buildup can cause headaches, often described as dull and persistent. But the really classic sign comes when the tumor grows upwards out of the sella.
Towards the optic nerves.
Precisely. It presses on the optic chiasm, the place where the optic nerve fibers from the inner half of each retina cross over.
Compressing those crossing fibers causes what kind of visual problem?
It causes bitemporal hemianopia. You lose the outer peripheral visual fields in both eyes, like wearing blinkers. Patients might complain about bumping into things on the side or difficulty driving because they can't see cars coming from the periphery.
That's a huge red flag for a pituitary mass. What about the compression effect on the healthy pituitary tissue squashed by the tumor?
That's the other major consequence. The growing mass crushes the surrounding normal pituitary cells. This leads to progressive pituitary failure or hypopituitarism, just like we saw with Sheehan's, but developing much more slowly.
So you'd start to see deficiencies in the other pituitary hormones.
Yes. Typically, you lose gonadotropin function, at first low LH and FSH, leading to hypogonadism, then maybe TSH deficiency, causing secondary hypothyroidism, low TSH, low T4. ACTH deficiency can occur too, but often later.
Okay, so low reproductive hormones, low thyroid hormones. But there's one hormone level that can be paradoxically mildly elevated, which is a key diagnostic pattern here.
Ah, yes, the prolactin. This often confuses people. Why would a non-functioning tumor cause high prolactin?
Why indeed?
It's usually not the tumor itself making prolactin. It's because the large tumor mass compresses the pituitary stalk.
Yeah.
Remember, the stalk connects the hypothalamus down to the pituitary.
And dopamine travels down that stalk.
Yes. Dopamine from the hypothalamus normally travels down the stalk to inhibit prolactin release from the pituitary's lactotroph cells. It's the prolactin brake.
So if the tumor squashes the stalk,
It disrupts the flow of dopamine. The brake is released. The lactotroph cells become disinhibited and start secreting a bit more prolactin on their own.
but not massively high levels like a true prolactinoma.
No, typically just a mild elevation, often in that 25 to 100 ngml range we discussed earlier.
Yeah.
So the classic lab pattern for a large non-functioning adenoma causing compression is low LH, FSH, maybe low TSH-T4, combined with this mild hyperprolactinemia due to stalk effect.
That pattern plus the visual field defect really points towards this diagnosis and management if there's visual loss or significant hormone deficiency.
It's usually surgery, transphenoidal resection going through the nose to decompress the optic chiasm and remove as much of the tumor mass as possible.
To relieve the pressure and hopefully restore some function.
Exactly. Relieve the mass effect, save the vision, and sometimes pituitary function can even recover a bit once the pressure is off.
Okay, let's move to a different axis altogether, the control of water balance. We need to talk about diabetes insipidus, DI. And first things first, let's clear up the name. It sounds like diabetes mellitus, but it's completely unrelated to blood sugar, isn't it?
Completely different beast. Yeah. The name is confusing. Diabetes mellitus is about sugar, glucose, acting as an osmotic agent, pulling water into the urine. Diabetes insipidus is purely a water problem.
How so?
It's an inability of the kidneys to concentrate urine, to reabsorb free water. This happens either because the brain isn't making enough antidiuretic hormone, ADH also called a vasopressin, or because the kidneys aren't responding to the ADH that's there.
So without that ADH effect, the kidneys just let water pour out.
Tons of it. The defining feature is massive polyuria, peeing out huge volumes, often more than 3 liters a day, sometimes much more, of very dilute urine.
And if you're losing that much water, you're going to be incredibly thirsty.
Intensely thirsty. That's polydipsia. They drink and drink and drink just to try and keep up with the losses.
So diagnostically, how do you confirm it's DI and not just someone drinking a lot for other reasons? What's the key lab pattern?
You need to show that the urine is dilute despite the body having a reason to conserve water, meaning the blood is relatively concentrated. So you check serum osmolality and sodium and urine osmolality.
What do you expect to see?
In DI, the urine osmolality will be inappropriately low, often less than, say, 150 or 200 milliliters kilos dB caris because they can't concentrate it. At the same time, their serum osmolality and serum sodium will be high normal or, frankly, high, especially if they haven't been able to keep up with drinking.
So dilute urine in the face of concentrated blood, that's the hallmark.
That's the fingerprint of DI. It distinguishes it from, say, primary polydipsia, where people drank too much psychogenically. In that case, their serum sodium would be low normal or low, and if you restricted their water, they could concentrate their urine eventually. Hashtag tag Chap 3.2, the desmopressin challenge. This in treatment.
Okay, so we've confirmed DI based on that urine-serum osmolality mismatch. Now we need to know why. Is it central DI, the brain isn't making ADH? Or nephrogenic DI, the kidneys aren't listening to ADH?
Right, we need to localize the problem. And the classic way to do this is the desmopressin challenge, which usually follows a water deprivation test.
Explain the water deprivation part first.
You carefully withhold water under supervision, measuring urine output, urine osmolality, and serum sodium osmolality frequently. The goal is to see if, under the stress of dehydration, the patient can eventually concentrate their urine. If they can, it suggests primary polydipsia, not true DI. If the urine stays dilute even as the serum gets concentrated, that confirms DI.
Got it. So once DI is confirmed via water deprivation, then you give desmopressin.
Yes, desmopressin, or DDAVP, is a synthetic version of ADH. You administer it, often as a nasal spray or injection, and then you see how the urine concentration responds.
How does the response tell you if it's central or nephrogenic?
It's usually quite dramatic. If the patient has central DI, the problem was just lack of ADH. You give them desmopressin, and suddenly the kidneys have the signal they needed. They start reabsorbing water, and the urine osmolality shoots up typically by more than 50% from the baseline during deprivation.
A big response means central DI. And the treatment then is?
Lifelong desmopressin replacement therapy, tailored to control their urination and thirst.
Okay, and what if there's no significant response to the desmopressin?
If the urine osmolality barely budges, maybe increases less than 10%, That tells you the kidneys are resistant to the ADH signal. That's nephrogenic DI. Giving more ADH doesn't help because the receptor or downstream pathway in the kidney isn't working.
So treatment for nephrogenic DI is totally different.
Completely different. You first look for and treat any underlying cause. Is it medication-induced, especially lithium? Is it due to high calcium or low potassium? If you can fix the underlying cause, the DI might resolve.
And if you can't fix the cause or it's inherited,
And then, somewhat paradoxically, the treatment often involves using a thiazide diuretic, like hydrochlorothiazide, often combined with a low-salt, low-protein diet.
wait, a diuretic? That seems totally backward for a condition where you're already peeing too much.
I know it sounds crazy,
Yeah.
but thiazides work upstream in the kidney tubule. They cause mild salt and water loss initially, which leads to a slight volume depletion. This triggers the kidney to increase water and salt reabsorption in the proximal tubule before the fluid even reaches the collecting duct where ADH normally works and is failing to work in NDI.
Ah, so by forcing more reabsorption earlier on, less water gets delivered to the broken part of the system downstream.
Exactly. It reduces the overall volume of fluid reaching the collecting duct, thereby reducing the final urine output. It's a clever workaround.
Clever indeed. Now, there was a strong warning in the sources about managing DI patients, especially during diagnosis. Never restrict water.
Absolutely critical point. You can perform a supervised water deprivation test in a controlled setting for a limited time, but you should never tell a patient with known or suspected DI to just stop drinking water freely at home or restrict their fluids long term,
Why is that so dangerous?
because they are obligate water losers. They will continue to excrete large volumes of dilute urine regardless of intake. If you take away their ability to replace that lost water by drinking, their serum sodium will skyrocket very quickly into dangerous territory. Severe hypernatremia causes brain shrinkage, neurological damage, seizures, coma. It's life-threatening. They must always have free access to water. Hashtag tag 3.3 DI in pregnancy, the enzyme factor.
Okay, one more fascinating wrinkle with DI pregnancy. Why can pregnancy sometimes trigger or worsen DI? This seems really specific.
It is. It's a beautiful piece of physiology, actually. It turns out the placenta, during normal pregnancy, produces an enzyme called vasopressinase.
Vasopressinase sounds like it breaks down vasopressin or ADH.
Exactly what it does. It's very efficient at degrading the mother's endogenous ADH. Normally, a healthy woman produces enough extra ADH to overcome this breakdown.
But if a woman has maybe a mild underlying previously undiagnosed issue with making ADH,
Like a partial central DI where she was just barely compensating before pregnancy, the massive increase in vasopressinase activity during mid to late pregnancy can overwhelm her limited reserves. The enzyme just chews up her ADH too fast.
and suddenly she develops full-blown DI symptoms, the intense thirst and urination.
Precisely. It's called gestational DI, often transient, appearing in the second or third trimester.
How do you treat this? Can you still use desmopressin?
Yes, and importantly, desmopressin, DDAVP, works particularly well here. Why? Because its molecular structure has been modified slightly compared to natural ADH.
Making it resistant to that placental enzyme.
Exactly. Vasopressinase can't break down DDAV effectively, so DDAVP provides a stable ADH signal that bypasses the placental degradation.
Clever. And then usually the DI resolves after delivery when the placenta is gone.
Typically, yes. Once the source of the vasopressinase is removed, the underlying physiology returns to its baseline, which might be normal or might reveal a mild pre-existing DI that needs further evaluation postpartum.
Okay, before we wrap up with key takeaways, let's circle back to something we touched on earlier, drug side effects mimicking pituitary problems, specifically antipsychotics causing high prolactin. This must come up a lot clinically.
It really does. It's one of the most common reasons for finding mildly elevated prolactin. Especially with certain second-generation antipsychotics, risperidone is probably the most notorious offender, but others can do it too.
And the mechanism ties back to dopamine, right?
Directly. Remember we said dopamine from the hypothalamus acts as the natural brake on prolactin release from the pituitary?
The tonic inhibition.
Well, many antipsychotics work by blocking dopamine D2 receptors in the brain to treat psychosis. Unfortunately, they also block D2 receptors in that specific pathway, running from the hypothalamus to the pituitary, the tuberoinfundibular pathway.
So they block the dopamine brake in the pituitary, too.
Exactly. By blocking the inhibitory dopamine signal, prolactin secretion is disinhibited and levels rise.
Leading to the same symptoms as a small prolactinoma, irregular periods, galactorrhea, low libido. So how do you tell the difference? If a patient on risperidone comes in with these symptoms and high prolactin, how do you know it's the drug versus a tumor?
Two main clues usually help distinguish. First, the level of prolactin. As we mentioned, drug-induced hyperprolactinemia almost always causes only a mild to moderate elevation, typically in their 25 to 100 ng/ml range, maybe up to 150 sometimes. It rarely goes above 200.
Whereas prolactinomas, especially macrodenomas, are often much higher, over 200, sometimes way into the thousands.
Correct. Second, look for symptoms of mass effect. Patients with drug-induced elevation generally don't have headaches or visual field problems because there's no tumor mass causing pressure. If those symptoms are present, you need to think tumor regardless of the medication.
Okay, so moderate elevation, no mass effect symptoms, patient on a known offending drug strongly suggests drug-induced. What's the management then?
Usually, if the symptoms are bothersome, the best approach is to try and switch the patient to a different antipsychotic that is less likely to raise prolactin, what we call prolactin sparing.
Which ones are those?
Agents like aripiprazole, quetiapine, sometimes olanzapine, tend to have lower D2 receptor blockade in that specific pathway or have other properties that mitigate the effect. Switching often resolves the high prolactin and the symptoms quite nicely. Hashtag 4.2 review of key takeaways for the learner.
All right, we've covered a huge amount of ground, from overactive glands to failing ones, tumors, drugs, water balance. Let's try to distill the absolute key diagnostic differentiators, the things you absolutely need to remember from these sources.
Okay, rapid fire synthesis. 3 main areas we hit hard.
First, water balance. If you see someone peeing buckets, polyuria, and their urine is dilute, what's the immediate next step?
Check their serum sodium and osmolality. If the serum is concentrated, high or high normal, think diabetes insipidus. The desmopressin challenge to separate central responds well from nephrogenic, poor response. And remember, the special case is vasopressinase in pregnancy and using thiazides paradoxically for nephrogenic DI. And never restrict their water.
Okay. Second area, adrenal insufficiency. If you suspect low cortisol, maybe hypopituitarism signs, what's the single best clue to locate the problem pituitary versus adrenal?
Look at the aldosterone level. If aldosterone is normal, the RAS is working, the problem is central, secondary AI. ACTH will be low and no hyperpigmentation.
And if aldosterone is low, along with cortisol?
Then the adrenal gland itself is shot, primary AI Addison's. ACTH will be sky high, leading to that telltale MSH-driven hyperpigmentation. And they'll have salt wasting and high potassium too.
Perfect. Finally, the growth and reproductive axis. If you see those striking physical changes, coarse features, big hands, jaw growth, what's the first test?
Screen with IGF-1 for acromegaly. Don't bother with random GH. And remember the killer complication, concentric LVH. That cardiac risk is paramount.
And for the prolactinoma, often presenting with reproductive symptoms or galactorrhea, what's the crucial long-term reason to treat beyond just symptoms?
Bone loss. Chronic estrogen deficiency or testosterone deficiency from the GnRH suppression leads to osteoporosis. Protecting the skeleton is key. Check the prolactin level. Very high suggests macroadenoma. Moderate levels need a wider differential, including drugs and hypothyroidism. Hashtag outro.
Wow. That was a genuine deep dive. It's really quite incredible, isn't it, how the function or dysfunction of this tiny little gland buried at the base of the brain can dictate so much about a person's physical state, their metabolism, their ability to have children, even just stay hydrated.
It really underscores why endocrinology requires such careful detective work. It's often about piecing together these subtle clues, the aldosterone being normal, the prolactin being only mildly high, the specific type of heart thickening. Recognizing those subtle connections is what leads to the right diagnosis.
That ability to see the pattern, to know which clue matters most, is everything. But thinking about the pituitary's physical situation, I want to leave our listeners with a final thought, something that connects back to Sheehan's and the non-functioning tumors.
Go on.
The pituitary gland itself, the master regulator, seems almost uniquely vulnerable physically, doesn't it? We talked about how its anterior lobe relies on that fragile, low-pressure portal blood supply, making it susceptible to infarction, like in Sheehan syndrome.
Right, the ischemic vulnerability.
And at the same time, its location, packed into the sella turcica, right under the optic chiasm, makes it incredibly vulnerable to compression from tumors growing within or near it, leading to visual loss.
True, it's anatomically precarious.
So the provocative question I'm left with is this. How does this inherent physical fragility, this susceptibility to both vascular collapse and mechanical compression, simply due to its plumbing and its address, shape our understanding of hormonal regulation and stability? What does it mean that the body's central command post is built in such a vulnerable spot?
That's a fascinating question to ponder. Something about the trade-offs in biological design, perhaps. Definitely food for thought. Until next time, keep digging into those sources.
Absolutely. We'll see you on the next deep dive.